Dear Professor Lotan, dear colleagues and friends, once again I would like to thank you for providing the ESC the opportunity of organizing with IHH this joint session, and I would like to thank you for the overwhelming hospitality that we are enjoying. In the next 20 minutes, this is my disclosure slide. In the next 20 minutes, I would like to briefly review with you what are the successes that have been obtained in heart failure management, what are the failures, what are the new drugs underway, are there new devices or procedures which are promising, just touch upon other non-pharmacological measures, and just say a word to conclude on telecardiology. The first question is, have we made progress? And I think it is fair to say that yes, indeed we have made progress thanks to life-saving drugs such as ACE inhibitors or ARBs and beta blockers. And this is shown on this slide, which puts in perspective the annual mortality rate from the area of before ACE inhibitors, that was a SOLVE trial in the placebo arm, going to the recent trials such as SHARM, and you can see that the annual mortality rate has declined from approximately 16% per annum to 6% per annum. So indeed, we can be proud of the achievements that have been obtained in chronic heart failure. This is true not only for mortality, but for hospitalizations. This is Scottish data, which shows in blue in men and in pink in women the rate of age-adjusted rate of hospitalizations for heart failure. And you can see that there has been a substantial decline from 1995 approximately, which was the time when ACE inhibitors were widely used in the management of chronic heart failure. And so I think that this progress is certainly related to the fact that the international guidelines that major institutions such as the ESC have released have been widely applied. This is recent data from the pilot survey performed across 10 European countries by the ESC in chronic heart failure. And you can see that the rate of prescription of ACE inhibitors, ARBs, and beta blockers, as well as aldosterone blockers, is quite high. So indeed, in real-life situations, we do apply what the international guidelines suggest us to do. However, if you look at the residual risk which exists in both chronic and acute heart failure, there is still room for improvement. This is another result of the pilot survey performed by the ESC in chronic and in acute heart failure. And you can see that the rate of all-cause mortality or heart failure hospitalizations remains approximately 17% in chronic heart failure in Europe and more than 35% per annum in acute heart failure. So indeed, there is still room for improvement. What are the recent successes? There have been two important trials which have been presented in chronic heart failure. The first one is SHIFT, in which I took part, which used a new bradycardic agent called ivabradine, which is an inhibitor of the sinus node IF current, and indeed, on top of the best possible recommended therapy, the addition of ivabradine reduced, as you can see, the primary composite endpoint, which was made of cardiovascular death or hospitalization for heart failure, by 18%. Importantly, this agent also reduced very significantly the rate of heart failure hospitalizations compared to conventional therapy by 26%. There was also with this drug an improvement in quality of life, which was assessed by the Kansas City Cardiomyopathy Questionnaire with a significant improvement compared to the placebo arm. Ivabradine is in yellow and placebo in white at 12 months. And we believe that the explanation for the benefit observed with this drug is the fact that indeed ivabradine added on top of conventional therapy induced a significant reverse remodeling. You can see here in this echo sub-study that at 8 months there was a significant reduction in left ventricular diastolic and end systolic volume index compared to placebo. The second important clinical trial is Emphasis. Emphasis tested the benefit of a new anti-aldosterone agent, eplerenone, in mild heart failure. It enrolled approximately 2,800 patients in NYHA class 2 with an ejection fraction of less than 35%. And eplerenone was up-titrated to 50 milligrams per day. And this trial was prematurely interrupted because of the benefit observed with eplerenone, here again given on top of conventional therapy. This is the primary endpoint. You can see that the addition of eplerenone in yellow to conventional therapy significantly reduced by 37% the occurrence of cardiovascular mortality or hospitalization for heart failure. And importantly, here again, this new agent significantly reduced the occurrence of heart failure hospitalization with a risk reduction of more than 40%. The second area I would like to touch upon is the benefit brought by devices in heart failure. And the first kind of devices which has indeed improved mortality are, of course, defibrillators. This is a landmark trial which was published a few years ago, SCADEFT, and you can see that there were 3 arms, placebo, amiodarone, and ICD. And in these patients with moderate heart failure, low ejection fraction, the implantation of an ICD significantly reduced the mortality rate, and this has been, of course, translated into international guidelines for patients with heart failure and this kind of profile. The second major progress is, of course, cardiac resynchronization therapy. And there were 2 landmark trials which definitely provided proof that this CRT is beneficial in heart failure. The first one was Companion, and the second one was CARE-HF. And in the 2 trials, you can see that CRT-P or CRT-D significantly reduced the occurrence of deaths or cardiovascular hospitalizations. And here again, nowadays, in international guidelines, this has been translated. And if we put in perspective these results of cardiac resynchronization therapy in the same way as I showed for pharmacology, you can see that in severe heart failure, because at the moment CRT is recommended only in severely symptomatic heart failure, we have made progress with an annual mortality rate in the years 1995, which was around 27%, down to 10% per annum after CRT. So indeed, we have made progress. However, there are failures in the management of heart failure, and there are 2 areas where we have not been so much successful. The first area is the management of acute heart failure. This is a slide which summarizes 4 recent trials which were conducted in acute heart failure or acutely decompensated heart failure. And you can see that whatever the kind of drug, enoxaparin, which is a new inotropic agent, levosimendan, which is a calcium sensitizer, or tolvaptan, which is an arginine vasopressin antagonist, the result was neutral or even harmful, such as Revive with levosimendan, where there was a trend for an increased mortality. This is the primary endpoint of Everest. Everest used tolvaptan, the arginine vasopressin antagonist, and you can see that there was absolutely no effect in the active arm on any of the 2 long-term endpoints, whether it is all-cause mortality or cardiovascular mortality or heart failure hospitalization. The same applies to Survive, which used the calcium sensitizer levosimendan, the comparator being dobutamine, and there is absolutely no difference between the two arms. And this is all the more unfortunate as you can observe that the mortality at 6 months in this trial was extremely high, in the range of 27%. Recently, the adenosine antagonists have also been tested in acute heart failure, and unfortunately, it was not a success. This is a drug called rolofylline, which was tested in a trial called PROTECT. And this is the primary endpoint, which was the proportion of patients either failing the treatment, unchanged in blue, or improved in green. And you can see that there was absolutely no difference between the placebo arm and the rolofylline arm, and indeed this kind of drug has been, the development of this kind of drug has been stopped because of absence of efficacy and of adverse events such as seizures. Another disappointment was the ASCEND heart failure trial, which tested in a very large population of approximately 7,000 patients the benefit of infusion of neseritide, which is a recombinant natriuretic peptide. And unfortunately, in ASCEND heart failure, we observed no significant difference on the primary outcome, which was at 30 days, mortality or heart failure hospitalization, or on any of its two components, and the only benefit was a very moderate effect on dyspnea score. Why have we been failing in acute heart failure? I think that there are three explanations. One is the inclusion of heterogeneous populations in terms of substrate, of trigger of the acute heart failure episode, or even of pathophysiology. Two is the lack of unanimity on a standard comparator to be used in acute heart failure. And three, the lack of consensus on dosing, time points, and endpoints to be measured in this condition. The second area where we have failed is heart failure with preserved ejection fraction, which represents in series between 30 and 50% of the overall heart failure population. These are two trials which use renin-angiotensin system blockers in heart failure with preserved ejection fraction. Was charm preserved using candesartan, an ARB. The other one was PEP-CHF using the ACE inhibitor perindopril. And you can see that none of these two trials was convincing in terms of improvement of the primary composite endpoint. We published 2 years ago iPreserve, which is a very large trial in heart failure with preserved ejection fraction. And here again, you can see that the addition of irbesartan, an ARB, compared to placebo on top of conventional therapy was not associated with any improvement in the occurrence of death or cardiovascular hospitalizations. And we are therefore eagerly waiting for the ongoing trial with spironolactone in elderly patients with heart failure and preserved ejection fraction, which is currently conducted in North America. We will get the results probably in 2 years from now. We have no clear explanation why we have not been successful in heart failure with preserved ejection fraction. Is it that the hypothesis is wrong? Is it because we include patients who are at a very late stage of their disease with fibrotic heart? We obviously need to go back to bench in order to try to identify the factors that led to this failure. The next point is to briefly address the new drugs which are currently tested or will be tested. I will briefly touch upon renin inhibitors, new inotropic agents, new vasodilators, chimeric natriuretic peptides, and finally complex molecules, including a NEP inhibitor effect together with an ARB. The first outcome trial to be conducted with a renin inhibitor, which is aliskiren, is currently underway. This is to show you the design of the trial, which is called Atmosphere. It is an outcome trial in a large population of 6,600 patients The primary outcome is cardiovascular mortality or heart failure hospitalizations, and Atmosphere will compare an arm treated by enalapril 10 milligrams twice daily, aliskiren, the renin inhibitor, 300 milligrams once daily, and the combination of the two drugs. I would like to briefly address these new molecules developed by Novartis, which at the moment has no name, only a number, which is a molecular complex called ARNI, which has an ARB valsartan-like activity and a NEP inhibitor activity. I recall you that NEP is the enzyme which cleaves the loop of the natriuretic peptides and therefore makes these peptides becoming inactive. There is a large outcome trial which have been started, here again not finished, which is called Paradigm Heart Failure. It is very similar in design to Atmosphere, and this trial will compare the efficacy of this new complex molecule provided 200 milligrams twice daily to once again a regimen made of enalapril 10 milligrams twice daily. Here again the primary composite is cardiovascular mortality or heart failure hospitalizations. One word on new vasodilator agents. Relaxin is a new agent which has a lot of different pharmacological properties, including vasodilation, anti-inflammatory, anti-apoptotic, and so on, and it has been tested successfully in a proof of concept study. It is currently tested in a second trial, so we have to wait for the result. One word on chimeric natriuretic peptides, which are developed by John Burnett's team at the Mayo Clinic, in particular this compound which is called CDNP and which combines the activity of CNP, which is a vasodilator, with DNP, which preserves renal function. Here again, we have to wait for proof of concept trial to see whether this approach is beneficial in heart failure patients. One word on instaroxime, a new inotropic agent, which has indeed a dual mechanism of action. It is one, a sort of digitalis-like because it blocks the sodium-potassium exchange at the sarcolemma level, but it has also an action on the reuptake of calcium by the reticulum, the sarcoplasmic reticulum, and therefore it is believed that this agent might be beneficial in acute heart failure, and indeed some preliminary studies have shown some good results with this drug. Recently, a new direct mousing activator called omecamtiv mecarbil was presented in a trial, and this trial was published in the Lancet, with indices of cardiac function which improved with the administration of this agent in acute heart failure. Let me briefly touch upon new devices and new indications for CRT. First of all, there is a major development of new devices for ventricular support, and you can see that these new devices are miniature devices, and indeed there is a trend in many countries, including in my institution, to move from bridge to transplantation to destination therapy with left ventricular assist devices. Of course, there is a problem of cost and affordability, but due to the shortage of donors for heart transplantations, this is a general trend that we observe for a move towards destination therapy for LVADs, and once again a major progress in the size of these devices. What about new indications for CRT? There are two trials which suggested that cardiac resynchronization therapy can be used successfully not only in severe heart failure, but also in mild to moderate heart failure. One is transatlantic, it was REVERSE, and this is the European arm of REVERSE, which showed that in those patients who had their CRT off compared to those patients who had their CRT on, there was a significant increase in the proportion of worsening patients, suggesting therefore that this therapy is beneficial in mild to moderate heart failure. And one likely hypothesis for the benefit brought by CRT is that the fact that it induces a reverse remodeling, as observed here, where you can see that left ventricular and systolic volume index was significantly reduced in those patients with their CRT on compared to those patients with their CRT off. The second trial, which brought some evidence for the benefit of CRT in mild to moderate heart failure, is the RAFT trial, which enrolled patients in class 2 to 3 low ejection fraction, and indeed the implantation of a CRT significantly reduced the rate of all-cause mortality or heart failure hospitalization by 25%, and more significantly reduced hospitalization for heart failure by 44%. One word on cell therapy, which is ongoing. There are two different approaches for those who are trying to develop cell therapy in chronic heart failure: the use of cardiac skeletal muscle myoblast injections, or the use of embryonic or bone marrow stem cells. I have to say that the results so far remain for me a question mark, and we definitely need outcome studies to know whether this approach may be beneficial in the management of chronic heart failure, not to speak of the cost of development of these therapies. The second biological approach is, of course, the gene transfer, and in particular, you have this ongoing trial, which is a transatlantic trial in which we are part of together with Boston, which is the agent heart failure trial, where we will inject the gene coding for SERCA. SERCA is a key enzyme involved in the reuptake of calcium by the sarcoplasmic reticulum, and it is downregulated in chronic heart failure, and we will inject by coronary approach this gene in order to see whether we improve the cardiac function of these patients. One word on non-pharmacological approach, and I would like to mention this European trial which was called Heart Failure Action, which tested the benefit of a program exercise in patients with heart failure. The primary outcome was negative, but the secondary outcome made of cardiovascular mortality or heart failure hospitalizations was significantly improved in those patients who were enrolled in this intensive exercise program in chronic heart failure. So this is just to mention that we should not forget that besides pharmacological or device approaches, we need to apply good lifestyle measures to patients, and this includes exercise adapted to the functional limitation of the patients. One word to finish with telemonitoring. There are lots of ongoing studies which try to develop remote distance control of heart failure patients, including their symptoms, their vital signs, with implantable devices or with a nurse calling patients on a regular basis. And there are some meta-analyses which have shown that telecardiology indeed improves outcome in chronic heart failure. This area, I am sure, will be very much developed in the next few years. Thank you very much. Toda raba.